catheter in, because that, especially when you're talking on the phone with me or poison control, it's going to be really helpful for something that's very objective, as opposed to how moist or dry somebody's skin is, or how big their pupils are in a brightly lit ER. If you tell me that you put a Foley in and there was a liter of urine, that's a pretty objective finding. You want to get an electrocardiogram to screen for tricyclics again, because they're the deadly ones and they're the ones that are treated completely differently. So assuming that you're not dealing with a tricyclic, the treatment is A, B's, and C's, decontamination, and here, unless it's like a BZ exposure, which shouldn't exist, GI decontamination is the decontamination I'm talking about here. It's important because if somebody's alert enough to do it, remember that antimuscarinic slows GI motility, and so you may have a burden of drug in the stomach that's going to continue to be absorbed and make the patient sick for a prolonged period of time. So if you can, you want to get some charcoal into them. Maybe it'll shorten the course, but certainly not worth being aggressive and putting an NG tube or anything. We'll talk more about GI decontamination in a different lecture. Some patients may need to be restrained or sedated in order to take care of them safely. They may be really agitated, particularly if it's a non-antihistamine anticholinergic. Right? So antihistamines are naturally sedating, but if you just take an atropine overdose, there's no sedating part of it to counteract some of that delirium, so you're going to be particularly agitated. Think about our antidote, physostigmine. So the indications for physostigmine are both central and peripheral signs of anticholinergic. So the central delirium, the hallucination, picking of the air, as well as all the other stuff, the antimuscarinic effect. And then rule out tricyclic by EKG. It used to be pretty routine that physostigmine would be given to a lot of patients with altered mental status because it's a non-specific analeptic, kind of like caffeine. It wakes you up for whatever reason. And so it was given much more liberally in the past. And then there were 4 case reports of patients who were poisoned by tricyclics and got physostigmine and had asystole, pretty much the worst adverse effect you could have of an intervention. And so people kind of got afraid to give physostigmine to anyone, and that's not the right lesson. The right lesson is don't give physostigmine to tricyclic antidepressant poison, because they're much different drugs than other antimuscarinic drugs. They do a lot of other things that are dangerous. So, Joel?
Yeah, so I will use physostigmine, you know, with someone who's really bad that I've ruled out it being Elavil or one of the other tricyclics. I think it's short acting, and you don't want to keep giving it, but it may help you get the history, it may help you make the diagnosis, it may help you to get the patient's act together enough so you can get everything done. The problem with it is that it can cause seizures. You obviously can overdo it and they can become bradycardic and hypotensive, so you have to be careful. I always say in an adult, the maximum I would give at a time would be 2 milligrams, and I would always do it in increments, 0.5 to 1 milligram, and you can repeat that in a few minutes, in 5 minutes, up to no more than 2 milligrams to start with. I found was safe, and you could do it that way.
So, Joel, I have a question. Have you ever seen someone seize or get cholinergic from getting physo?
Yes. I had a case at Lincoln, a young woman who took an antihistamine, was very agitated, and I had a case with Dr. Casey when he was a resident, and we gave, you know, it was Benadryl, we gave the physo, and she actually had a seizure. This is the only one I've seen caused by it, and I'm not sure what else, you know, maybe she's going to have the seizure anyway. But more of what I've seen is that in the really bad ones, it works, it helps you get things done, and then they go back down, and then you don't need to keep repeating it. Then you can just, you got everything done you need. You could sedate them with, with benzos if you need to. And I just felt it made things easier. So I've used it. I've had good success with it in the right situation, but not with tricyclic.
So I would say, yeah, definitely don't use it in tricyclic. I think there's no argument about that. I would say, as long as you're giving it to the right patient, it's extremely safe, as long as you're careful with it. You don't want to give it too fast. You definitely don't want to give it as a diagnostic test. If you're not sure what that is, then you shouldn't be giving it. You should consider it treatment for somebody that you've already clinically made the diagnosis. So I can tell you that, at a certain point where people got kind of afraid to use the physostigmine, a whole generation of ER docs kind of just sedated these people with a benzodiazepine and let them sleep it off, and that's okay. I'm going to give you a couple of counter arguments for why it's good to use physostigmine. One, this not great study by Michelle Burns in 2000, it's a retrospective study, but looked at people who were treated with benzodiazepines versus people who were treated with physostigmine, and the group that got treated with physo had shorter time to recovery and fewer complications than the patients who got treated with just sedation. Then let me give you another reason why it's a good idea to give physo. It proves your diagnosis. It shows that you were right based on your clinical impression. So it's not a diagnostic test, but it can confirm your clinical impression. And so just picture you have this patient who you've made the diagnosis of anticholinergic poisoning, they're delirious, they're hyperthermic, they have dry skin. You go to the medical admitting resident and say, oh, I got this anticholinergic patient, I gave him some Valium, and he just needs to sleep it off for a few days. What are they going to say? They're going to say, did you do the LP, right? We say he's hyperthermic, but they might say he has a fever and he's altered. Maybe he's got a meningoencephalitis. So, it prevents you from having to do some potentially invasive things that you might otherwise have to do. Because if you give physostigmine to a person who's anticholinergic, they become normal. It's amazing. It's like giving dextrose to a person who's hypoglycemic. They completely normalize. Somebody who's completely delirious will turn into a normal person. So that's a benefit. And maybe you can do some other things. You can give them some charcoal, they can cooperate with that, you can do the rest of your workup. And although it does wear off in about an hour, they don't tend to get quite as bad as they were before you gave it. So, I don't know if it's the charcoal that made these patients do better, maybe that, when they got better and they were able to get some charcoal, it shortened the course because they stopped having the continued absorption. But for whatever reason, I think that there's a number of arguments to be made in favor of using physo, but it's definitely not wrong to just sedate someone also.
I just got one more thing. We had an epidemic once at Lincoln.
Oh, don't say it. We're going to get to that.
Oh, okay.
I know what you're going to say, don't say it. Okay, so if you're going to use it, just respect the drug. Put the patient on a monitor because they can get bradycardic if you give too much. Have atropine at the bedside in case you were wrong. I've never been wrong about this, and you shouldn't be. You should be giving it to somebody that you're certain what the diagnosis is. Take a milligram or two, dilute it out into 10 mLs with some saline so you can give it really slowly, and give it very slowly over 5 minutes, just a little bit at a time. And as you're doing it, they should be getting more lucid, making a lot more sense. Their speech should be getting clearer. If you start to see cholinergic signs, they puke, they start to get diaphoretic, they get brady at all, then stop. Then you have the wrong answer. But if that doesn't happen, then you can keep going. And if you get it to the end of your milligram and they're not better yet, but they're also not cholinergic, it means you were right. They just need some more. 1 milligram of physo should make anyone really cholinergic. So that if they've gotten a milligram and they're not cholinergic, then they definitely were anticholinergic before you started. All right, next case.
I have a question.
Yeah.
So if you don't see any signs of TCA ingestion on the EKG, but you're still worried about other co-ingestants, would you still give physostigmine?
So the other co-ingestants that I'd be worried about would be TCAs. I think I would still give it as long as the overall clinical presentation was consistent with anticholinergic. And I've ruled out tricyclics by EKG. The caveat to that is I would say if they took a significant sedative overdose, so they took a bunch of opioids or they took a bunch of a sedative-hypnotic like a benzo, and they're sedated and you can't really monitor their mental status, then I wouldn't give physo because that's one of the big parameters that you're going to be checking to see whether you're at your endpoint, which is a good mental status. So if they're already sedated from a bunch of other stuff they took, then I probably wouldn't use it. But if clinically the main thing you're seeing is just anticholinergic, then I think you can go ahead as long as the EKG looks okay.
Just quickly spraying off of that, how quickly would you see EKG? stringent for TC?
So very quickly.
Very
So people who are going to die of tricyclics die within 6 hours, and they're really sick by hour 2. So certainly by 2 hours post-ingestion, you're going to have significant EKG changes, and probably even sooner than that if they took a significant overdose. Yeah?
Just a comment, that's when I was on my posture review, they kind of put the EKG as part of the tox physical exam.
Yeah, I would agree. I usually think of my initial evaluation of the tox patient as A, B, C, D, finger stick, E, EKG, F, physical exam. Right? That's so it's even more important in some ways than the toxicologic physical exam, which is where you're going to pick up your toxidromes. All right, next case. 21-year-old man brought in agitated and confused by the cops. He's seen putting something in his mouth after his car was pulled over. His vital signs are significant for hypertension and tachycardia. He is hyperthermic, SAT is normal, and he's agitated, screaming, diaphoretic. His pupils are big but reactive. Vital sounds are normal. What's that? Yeah, it sounds like it. What's the toxidrome? Okay, sympathomimetic. So it could have been cocaine. EKG is sinus tach. QRS is maybe a little bit big. QT is normal, no terminal 40 millisecond right axis, and no ischemic changes. He gets treated with diazepam, 10 milligrams at a time, up to 80. Gets a cooling blanket, and as he calms down, his vital signs go back to normal. Several hours later, he says he stuffed his bag of crack vials after the police pulled him over. Stuffing is trying to conceal evidence of a drug that you have on you, different from body packing, which is trying to carry a large amount of drug across the border. We had a body packing case last week, I think, in county. Yeah. All right. So in terms of adrenergic toxidrome, so you didn't have to know that was cocaine, though. You just had to recognize that this was the adrenergic toxidrome. And examples of adrenergics include cocaine, amphetamines, arohexamines like PCP, ketamine, dextromethorphan, methylxanthines, and in this case, we're not usually talking about caffeine, we're talking about pharmaceutical theophylline. And here it's a little bit different than the things that affect the cholinergic system because it's basically stimulation in the brain that leads to downstream stimulation of the sympathetic. So it doesn't matter whether you're using the acetylcholine muscarinic receptors as your neurotransmitter like you are in the sweat glands, or norepi, which you are for the rest of the sympathetic system. They're all stimulated because it's coming from upstream. So making the diagnosis, just think of your fight or flight response. Everything's revved up. So they get hypertension, tachycardia, agitation, hyperthermia, diaphoresis, and they get large pupils. And the things that are going to kill you are typically going to be hyperthermia, tachydysrhythmias, and bleeds. We're just getting out of the season where cocaine patients are most at risk. I have to add a slide, I should do this, but there's a great study at New York City Medical Examiner's Office on looking at cocaine deaths on a given day by ambient temperature on that day. And if you look, for most temperatures, the number of cocaine deaths is about 1 a day. So somewhere in New York City, someone dies of cocaine on any given day. As the temperature gets to 89, it starts to sharply go upward, and for every degree above 89 degrees it is outside, you have more and more cocaine deaths, and those are all hyperthermic deaths. So that's a major issue during the summer in New York. Bob Hoffman likes to talk about the clothes sign. If you're running around agitated on the street with your clothes on, it's cocaine. Running around agitated on the street with your clothes off is PCP. And so in order to treat the patient, really address the things that are going to kill them. So if they're hyperthermic, cool them down. The best way to do that is with an ice bath. And actually at Bellevue, where they see a lot of these patients, they have a special stretcher. It's a cholera bed, so it's like a stretcher chassis with a plastic basin with a drain in it. And you basically put the patient in there, pack them in ice and water, and you can rapidly get anyone's temperature down with that setup. Pretty low tech, but very effective. You'll see some people talking about mist and fan, and the data from mist and fan actually comes from US military studies in the first Gulf War, where they missed somebody and then put them under a helicopter that was on the ground. So that's kind of above and beyond what our typical fan setup is going to be at Kings County. You can also use a cooling blanket, definitely not as effective as dunking a patient in ice. You want to calm them down. So using diazepam or another benzodiazepine, Versed is a good one, especially if you don't have IV access. And then check for rhabdo, which can be a complication. So before I go into the last two, I'm just going to quickly go through to highlight the differences between the toxidromes, because especially the adrenergic and anticholinergic people get confused a lot. So the heart rate will be elevated for both adrenergic and anticholinergic. It'll typically be low for cholinergic, but you can still use the heart rate to some extent to distinguish, because adrenergic tachycardia is like putting your foot on the gas. You're flogging the heart with catecholamines. If you see a heart rate of 180, 200, it's probably not from an antimuscarinic. It's probably from an adrenergic. Anticholinergic is taking your foot off the brake, removing vagal tone. Maybe it gets you up to 120 or so, maybe a little higher than that. But so in that range, it could be either one. If it's really, really high, it's probably adrenergic. Blood pressure, only directly affected by adrenergic. So anticholinergic and cholinergic not really affecting your blood pressure, but adrenergic making it elevated. Your temperature will be high with both adrenergic and anticholinergic. Cholinergic doesn't tend to affect your temperature. Mental status will be, you'll be agitated with both adrenergic and anticholinergic, but the anticholinergic patients are really delirious. They're not oriented, they can't communicate effectively, they'll be talking gibberish, and they'll typically be picking at the air. Almost all of them wind up doing it. Whereas the adrenergic patient may be agitated, but they're typically oriented. If you can get them to answer your questions, then they'll normally know, the basic things about what's going on around them. Cholinergic patients can run the gamut between coma and seizures, so that can be very variable. But they usually won't be agitated. Pupils, they'll be large for both adrenergic and anticholinergic, but they're going to be reactive for adrenergic and not reactive for anticholinergic, because the adrenergic pupils are large because you're stimulating the radial muscles that pull the pupil open, but the sphincter that closes it is still intact, whereas the anticholinergic pupils are large because you paralyze the innervation of the sphincter that closes the pupil. Cholinergic pupils are typically small. Skin, here the unique role of the sweat glands in being sympathetically innervated, but using muscarinic acetylcholine as the neurotransmitter at the postganglionic synapse, can really help you. So the skin will be wet with adrenergic and cholinergic, but dry with anticholinergic. And then finally, urinary retention is classic for anticholinergic. You don't really see much effect on the bladder from the others.
Dr. Wiener.
Yes?
Also, that bowel sounds are also good for helping differentiate adrenergic.
Absolutely, yeah. And I didn't put that on here, but yeah, definitely the decreased bowel sounds in an anticholinergic patient can be a big clue as well. Yes?
Do you all see a lot of bath salts around here?
Not very commonly. No, it's not something that really took off in New York. But bath salts are basically an adrenergic, a sympathomimetic.
Right.
They're cathinones, and clinically they're the same as amphetamines. All right, next case, 32-year-old woman is brought in unconscious after being found collapsed in a nightclub. Her friends leave her after dropping her off at triage without leaving any contact info. I use the term friends loosely. These are her physical exam, basically normal vitals, statting well. She's unresponsive. She's got a gag reflex, and the physical exam is otherwise normal, but she's completely unresponsive. She gets the coma cocktail, thiamine, naloxone, and there's no response. She gets monitored, and over the next 12 hours, she gradually comes back to normal. Fascinating case, right? So, what toxidrome is this? Yeah, sedative-hypnotic. All right. So in this case, she wakes up and took 4 sticks. Sticks are Xanax. You didn't have to know that. You just have to recognize that this is the sedative-hypnotic toxidrome. The reason they're called sticks is because one of the formulations is this kind of long pill that's 2 milligrams. So if you have anxiety, you can take the whole thing. If you're really anxious, or break it in half, or just break a half a milligram off.
Bars.
Yes, that is also another name that is on the street. All right, but you didn't have to know that. You just had to recognize that this is the sedative-hypnotic toxidrome. And there's lots of sedative hypnotics out there: benzodiazepines, barbiturates, alcohols, including toxic alcohols, but also including ethanol. To my friend Gar in the Bellevue ER with some Georgie that he took from one of the Bellevue regulars. GHB and its congeners, gabapentolactone and 1,4-butanediol, and the inhalants, all of these are sedative hypnotics. So, principle of management. So first of all, the hallmark is coma with normal vital signs. Sometimes you can see hypoventilation or hypotension, particularly with barbiturates, with GHB. Typically, you don't see that with benzodiazepines. In fact, you can't really take enough benzodiazepines by mouth to make yourself stop breathing if you take it by itself. If you combine it with alcohol, it's really easy to have respiratory depression. So remember that combinations of sedative hypnotics are worse than a single one alone. So principle of management is first, do no harm. In general, just supportive care. If they need an airway, intubate them. Otherwise, for the most part, maybe they need some fluids. Otherwise, they mostly just need to be left alone. And when this came out, it was revolutionary. It was called the Scandinavian method. And at that time, there were a lot of people who were overdosing on barbiturates. It was a very popular drug. It was known as Mother's Little Helper, something that was given a lot to housewives to help them get through their day. And there were a lot of people who were overdosing on it. And that basically, physicians were really uncomfortable taking care of these unconscious patients, and they did a lot of things to try to wake them up. Things that sound crazy now, like strychnine and camphor and caffeine. And the mortality was pretty high. And then a group in Copenhagen said, hey, let's stop doing that stuff. Let's leave them alone. If they need to be intubated, we'll intubate them. If they need fluids, give them fluids, just supportive care. And the mortality dropped to almost zero overnight. It was all iatrogenic. So that was the Scandinavian method. So basically, leave them alone and just address the basics of critical care. All right, next case. 45-year-old man was brought in by BLS after being found untended on the subway platform. What's significant here?